thing that's thrombogenic about the particles is that they cause occlusion of the vessels. And because of the occlusion of the stasis, that promotes thrombogenesis. I don't think there's anything else about the particles that is thrombogenic.
Thank you.
Dr. Getrajman has his hand up.
Hi, this is Joelle Getrajman. I was the surgical ICU attending that was on this week when this patient was admitted. Thank you guys for inviting me. This is obviously, I think it was a great presentation. As you touched on, this is a really unique situation, only one other case report that you talked about. So I think that I also want to commend, like Dr. DiCenzo said, the persistence and advocacy for this patient, the timely involvement of consultants, and the re-involvement of the consulting teams, once the patient had looked like she was turning the corner and then appeared to, kind of start to deteriorate again. I think, in a situation like this where we're presented with something that we don't deal with every day, myself included, that, that was the most important thing in a situation like this.
I see that Dr. Kai has her hand up.
Hey, good morning, everyone. Great presentation. I'm Janet. I'm one of the cardiology fellows, and I was actually on service, when we were called about her last week. And she was such an interesting, I think, patient for us, because it's not something that we really see often. And we had gone down the track of thinking about all the different types of embolism that happened. And I'd actually reached out to a couple of our attendings on our side, just kind of for their input, because, everyone seemed to have a different, thought process or a different approach. And so I think that just speaks to how little we kind of know about, I guess, this process, and everyone's not really united on their front in terms of how the next step should be taken. But, I think one of the questions that we got was about the sort of the chronicity of this. Is it possible that she had pulmonary hypertension before she even came in, and maybe just with everything going on, it kind of was unmasked? And, I think, I had brought that up with one of our imaging attendings as well when they initially read the echo. I was like, is there a possibility for some sort of PFO or ASD? Because when you see isolated RA or RV enlargement, that is one of the possibilities. But she had said that we would usually expect to see some RVH and EKG changes that would tell us about sort of the chronicity of that. Because if it were an ASD or PFO, that would have been there her whole life. And we did not see that necessarily on her EKG. And so, we had sent her back for the bubble study. It came back negative, and so there is one type of VS, like a sinus venosus ASD, that you can't even see well on a TEE. Sometimes they get maybe like MRI or CT or something to visualize that. But once again, no sense of like chronicity from this. All of this seemed very acute. She came in satting 100% on room air, no symptoms. And then, sort of the morning after, before she was going to go into her operation, it sounded like she was already doing a little bit worse. So definitely an interesting situation. I think I'd be curious to see kind of how she progresses. I think from our heart failure side, there is an interest in maybe sending her to see, another physician at another center that does sort of lung transplantation, because they're curious, long term, what is going to be the effect of these microspheres? Will it cause fibrosis that may eventually lead to a need for lung transplant? Though that is probably going to be a very long time, down the road. I think it'll definitely be interesting to see. That may be our only confirmation.
Great. Well, thank you very much to the specialist who came and joined us this morning. We very much appreciate your input. And thank you, Naina, for an excellent job. All right. So in just a minute, I'm going to be asking Dr. Bachman to introduce our grand round speaker. But in the meantime, I'll just talk about attendance. We'll be taking attendance in the normal manner around 8:10 using your names in the participants list. If your name is displayed clearly, then you'll get full credit for attendance. The CME code will be distributed by the email system. And with that, Dr. Bachman, are you ready to introduce our speaker?
Absolutely. And I'm very, very happy to introduce a speaker that is talking on a topic that is near and dear to my heart. And it goes without saying that this person is someone who can really give us a lot of depth, a lot of understanding, and really an approach to how we deal with all individuals, especially those individuals who identify as non-cisgender individuals. So with that, I don't want to take too much of the time for his talking, but I'm very proud to introduce our speaker this morning.
Thank you so much, and I'm so glad to have been invited to share this presentation with you. My name is Peter Vasquez. I'm an associate professor of OBGYN at Penn, and I do practice the full scope of OBGYN still, but I do have a significant niche within my practice of caring for gender diverse patients. And just going to kind of share today with you a little bit about some, I think, important aspects for anybody in the field of OBGYN with an interest in caring for this population of patients. So let's see here. A few disclosures to start out with. I don't have any financial disclosures. In terms of terminology, I will be using just a little bit of shorthand. So I'll talk about transgender and gender diverse, or TGD, patients for brevity, but this may include patients and people with a variety of identities. I'm also going to be talking about the off-label use of FDA-approved medications, and I'll give just a little bit of a broader disclosure that much of the clinical practice in gender care is really not based on level 1 evidence. There's just not a lot of it. A lot of it is expert opinion and consensus. The objectives this morning, I want to talk about the role of the OBGYN in providing gender-affirming care, talk a little bit about preventative healthcare aspects specific to gender diverse patients, a few slides on obstetric care of gender diverse patients, and then talk about hormone therapy and hysterectomy, things that we as gynecologists can provide. To start with, some demographics, how many trans patients are there in the US? So the Williams Institute is a center out of UCLA Law, and they publish statistics every few years. Their most recent estimate is from 2022, and there are probably about 1.3 million transgender adults in the US, about 0.5% of the total population. There is a significant amount of intersectionality here as well. People who identify as transgender tend to be more ethnically and racially diverse than the population as a whole. And in addition to these 1.3 million adults, there are probably about 300,000 youth ages 13 to 17 who are trans. In one of their recent publications, they also decided to take a look at the non-binary population, and it's actually quite large as well. So 1.2 million people identify as non-binary, and that's actually about 11% of the LGBTQ population. Non-binary individuals, interestingly, are more likely to be white, more likely to be in the under 30 age group, and to live in urban areas. So, knowing that this is a small population, there's always the question of equity in care. So gender diverse people, like anyone, they need preventive health screenings. As a general sort of generalization, gender diverse people are at a higher risk for HIV and other STIs. Gender diverse people with a uterus are still at risk of unintended pregnancy. We know that when any population has marginalization, is marginalized, there are going to be increased risks of poor health outcomes. And specifically, trans and gender diverse people are probably going to be a little bit more reluctant to seek reproductive and sexual health care because they fear discrimination, because they are physically uncomfortable with the types of exams they think that they may need in coming to a GYN provider, because they're worried that their provider is just not going to know how to take care of them. And then financial barriers exist as well. So Cecile Unger, this is about 8 years old now, did a study just kind of trying to find out, like, are OBGYNs in general, are they knowledgeable about, are they comfortable in taking care of gender diverse patients? And at that time, only about a third of OBGYNs in academic settings said that they felt comfortable caring for TGD patients. So then why OBGYNs? So, why are these patients not going to their primary care doctor, their endocrinologist? And of course, many of them are, but I do think that we as OBGYNs are really uniquely and well positioned to be very involved in gender care for a few reasons. First of all, we are definitely experts in sex hormones. We are experts in puberty, in the menstrual cycle, in prescribing hormones for contraception and for menopause. So this is definitely our wheelhouse. We're obviously also experts in pelvic anatomy and pathophysiology, and whether the patient is a transmasculine or a transfeminine patient, there are likely going to be conditions that will make use of our expertise. And then lastly, we're really experts in guiding patients through life transitions, again, whether that be puberty or preconception, conception, pregnancy, delivery, menopause, all these life transitions that we become intimately involved with in patients' lives. And a gender transition, I think, fits nicely into that paradigm. And so then that begs the question, so as OBGYNs, aren't we women's doctors? Isn't OBGYN synonymous with women's healthcare? So a little etymology lesson here. So the two words that describe our field, obstetrics, this comes from Latin. The word obstetrics, which means one who stands before, referring to a midwife standing in front of a birthing person. And this acknowledges that pregnancy care was really the domain of midwifery until the 1800s. And then gynecology, based in the Greek roots for the study of women. So that's sort of where the etymology of our field comes from. Within the last probably, 30 to 40 years, we've started hearing a lot more about women's health programs, and this was meant to draw attention to the health disparities experienced by cis women. I don't need to tell the audience that these are very, very real disparities. We know that our cisgender women face barriers in terms of research funding, treatment options, the vast maternal morbidity and mortality crisis. We know that cisgender women are disadvantaged within the field of medicine still. But this women's health terminology sometimes was used a little bit more for marketing than in truly academic and scientific contexts. There's a sense now, I think, that it may be a little bit too narrow, but it's hard to completely feel comfortable with abandoning the terminology for that reason, that women continue to experience health equities and inequities rather. And so it's, I encourage people to try to get to a place of both and rather than either or. Yeah, that's still a challenge that we face within OBGYN. And then I think that, as a field, we're grappling with this painful history of knowing that modern gynecology is linked to American slavery, that the patriarchal systems in society and medicine have contributed to the development of OBGYN as a separate specialty from other surgical disciplines, and that we're very differently resourced. So why might a transgender patient need an OBGYN? So I won't go through each of these right now because we're going to touch on many of them in subsequent slides. But for reasons of hormone care, general pelvic and sexual health, surgery, contraception, pregnancy, birth, and postpartum care, all falling within the realm of general OBGYN. Our REI subspecialists are instrumental in fertility preservation as well as family building. CFP specialists are needed for the complex contraceptive needs that trans and gender diverse patients may have, as well as acknowledging that abortion care is also necessary. So undesired and abnormal pregnancies certainly do not exclusively occur in cis-het women. And there's a lot of stigma and sort of ambivalence in the trans community around pregnancy and pregnancy care. So diving right into some aspects of preventative healthcare. So this is, the next couple of slides are things that anybody can incorporate into their general practice, part of a routine maintenance visit. So, when I was starting med school now, probably around 20 years ago, it was still kind of cutting edge to ask people if they had sex with men, women, or both. And now that seems frankly a little bit reductive. So I put up here, and this is something that some of you may have heard, the 8 Ps of gender and sex history. Sometimes it's just 5 Ps. And, I'll admit that there's not going to be time in every visit to get into each one of these. But when you feel the need that you need to take a really comprehensive gender and sex history, I do recommend focusing on some of these. So the first P is preferences. So some of those are just preferences in terms of name and pronoun. Others are, finding out if there's specific terminology that may make the patient uncomfortable. Find out about their partners. How do their partners identify in terms of gender? What body parts do they have? And then in terms of practices, what body parts do you use for sex? Protection from STIs, past STIs. Talk a little bit about pregnancy. Are you having the type of sex that can result in a pregnancy? Do you want to become pregnant? Do you very much not want to become pregnant? And how are you taking steps to avoid that? The pleasure aspect of sex, is there any pain or difficulty? And then partner abuse, is there anything that you've ever been made to do that you didn't really want to? And that kind of segues into trauma-informed care. The other aspect of the routine visit that many patients are very fearful of is the pelvic exam. And specifically, trans and gender diverse patients may have a little bit more difficulty with this due to some past experiences, due to the fact that they may be on testosterone and that induces a lot of atrophy and makes the exam physically very painful. Maybe this is a trans feminine patient who has undergone a vaginoplasty and they're having some scarring from the procedure and that makes it very difficult. Our patients may not be having penetrative intercourse and they may just really, really feel dysphoric about talking about exposing their genitalia. So a few things that we can do to make the pelvic exam a little bit more acceptable. So, just really go over what is the rationale for this exam? What are we hoping? What information are we hoping to gain from this? Is it because there is a risk for an STI and you think that the pelvic exam is the best way to do this rather than urine-based testing? Is it to evaluate a specific symptom? And then talk about what the alternatives and what might be missed if we defer the exam. Obtain consent and emphasize the patient can decline or stop at any point. Establish some safe words. So say stop and I'll immediately pause. Say out and I'll immediately remove the probe or the speculum. And oftentimes you don't need to do this pelvic exam at the very first visit. You can establish rapport at the first visit and then come back for a second visit. Use the tiny speculum. You can give the patient a mirror, a hand mirror to watch, or you can even have the patient insert the speculum themselves. Distraction is great. Let them be on FaceTime or whatever to just sort of distract themselves. Have a support person present too, if that's possible. And then if it's related to atrophy, even if the patient doesn't want to be on estrogen over the long term, consider a short course of vaginal estrogen just to alleviate a little bit of that aspect of it. Hopefully we will, I don't know if your capabilities include primary HPV screening. We're not quite there yet, unfortunately, but hopefully we'll be there soon and that'll be amenable to self-swabbing. I mentioned that some patients may have some conflicting feelings about their anatomy, and you might need to elicit if there are any terms that you need to avoid to increase patients' comfort. So you can talk about if they have any preferred terminology. You can just take their lead. They might refer to a part of their anatomy when they're talking about something that is bothering them or brought them to the office, and so you can use that terminology. Sometimes I just use a little bit of a disclaimer. I say, I use standard medical and anatomy terms. Are there any words that you would prefer that I avoid? Or let me know if there's something that you don't understand or you're not comfortable with. And that usually works pretty well. Some common alternatives that I tend to hear patients using. So rather than referring to the vagina, they'll talk about the front opening. Chest is a common terminology for rather than breasts in a transmasculine patient. We'll talk about pelvic bleeding rather than vaginal bleeding. And then, a transvaginal ultrasound can be referred to as an endocavitary ultrasound. Again, a little technical sounding, but that is technically what it is. In terms of STI screening specifically, so the CDC guidelines recommend screening based on anatomy and sexual behavior. So there's not a lot of difference than what we would normally be offering, especially in terms of serologies. Those don't really differ from any age and risk-based recommendation. For vulvovaginal infections, so gonorrhea, chlamydia, trich, you can offer urinary testing. It does have good sensitivity and it's appropriate for asymptomatic screening. For trans feminine patients, so patients who have had a neovagina created, they're actually at really low risk of gonorrhea and chlamydia and trich. But if they are having symptoms, it may be worthwhile testing, or if they have a partner with a known infection, it's probably worthwhile testing. And patients can self-collect their swabs. Always consider that, PID can still occur in anybody who has a uterus. And so that may be a reason that you would emphasize the importance of a pelvic exam. And then again, this is something that goes for all patients, regardless of sex or gender. Consider triple site testing, depending on their sexual practices. In terms of cervical cancer, so trans men do have the same risk of HPV infection and cervical dysplasia, but they certainly are less likely to have routine screening and also less likely to use barrier methods. So the screening recommendations, again, do not differ for trans men specifically. For trans women who have had a neovagina created, there actually is, though, no role for screening PAPs or HPV testing of the neovagina. Most neovaginal canals are constructed either through a penile inversion technique, so they consist of keratinized epithelium. There's a peritoneal pull-through technique that is being used more frequently, and as it suggests, it's made out of peritoneum. Neither of these tissues are particularly apt hosts for the type of HPV that are going to be associated with genital cancers. That being said, especially the penile inversion technique, certainly is a good host for HPV-associated genital condyloma, and patients should be evaluated for that if they present with those symptoms. And then again, as we know, everybody should get HPV vaccinated. That is the best preventive strategy. Breast cancer screening. So this is an area where we actually just don't, frankly, have a lot of information because most of the population registries around breast cancer don't reliably record gender identity. But it does seem that transgender men who have undergone mastectomy and trans women do have significantly lower risks than cisgender women, but slightly higher than cisgender men. So in terms of trans women, women who either have had breast development as a result of hormone therapy, or who have, oftentimes patients will start with hormone therapy and then end up having breast augmentation. There is a suggestion that there might be a slightly younger age and a slightly lower rate of ER positivity in their breast cancers. But there's really no specific data on an optimal screening strategy. So most of the professional guidelines will just say to extrapolate from the guidelines for cisgender women. So we know that ACOG's guidelines say start at age 40, get it annually. Other guidelines in terms of USPSTF, they have recently changed them, but they suggest that you can start slightly later and have a slightly longer interval. UCSF and Fenway, both of which publish guidelines specific to trans screening, suggest every 2 years starting at age 50, but they acknowledge that this is not evidence-based. And then in trans men, so patients who have intact breasts who have not undergone top surgery should have routine screening. The amount of remaining breast tissue for patients who have undergone mastectomy, it will vary with the type of top surgery. But regardless, if a significant amount is removed, mammograms might not really be very feasible. But if a patient has a specific symptom or if they are a high-risk individual, you might want to consider alternate imaging modalities such as ultrasound or MRI. Contraception. The biggest take-home point that I always emphasize to patients is that gender-affirming hormone therapy does not provide reliable contraception. So if we think about it, physiologically, if a patient is on a sufficient dose of testosterone, for example, in a transmasculine patient, to completely suppress their hypothalamic pituitary gonadal axis, it should provide contraception. The issue here is that patients may not be taking their hormones completely consistently for a variety of reasons. It might be an issue of access. It might be an issue of forgetting. So we just really emphasize that if patients are having the type of sex that could result in a pregnancy, their hormone therapy alone does not provide reliable contraception. The good news is that they have a lot of options. Really any option is potentially acceptable, but anything containing estrogen is probably not going to be that acceptable to patients just due to the potential counteracting of the virilization that they're hoping for. As with everybody, we really encourage LARC. IUDs are fantastic. Nexplanon is great as well, progestin-only methods. Progestin is not feminizing, and so is really a great method for patients. All right, a few slides here now. I want to transition into some prenatal care aspects. So, I'll start this by saying that, again, this is an area where there's not a lot of specific information and a lot of specific data on how to care for patients, trans patients who are experiencing pregnancy, but just sort of a couple of best practice guidelines. So first of all, obviously, pregnancy is an extremely gendered experience, and this may in and of itself spark a lot of dysphoria for trans patients. So right at the beginning, you're going to just want to avoid using these common things we talk about: mom, maternity, acknowledging to patients that if you're handing out pamphlets and information, they're almost certainly going to have pregnant cisgender women on them. There's just not a lot of materials out there created for the trans population. terms of medical aspects, so first of all, establish the method of conception. Patients may have conceived spontaneously. They may have gone to a fertility practice, but home insemination is actually very common in the trans population. Again, due to this sort of concern of lack of understanding amongst the medical establishment. If a patient is presenting, you should assess the desiredness of the pregnancy and whether or not actually this was unintended. For example, maybe the patient has been using their testosterone recently and they did, sort of not realize that they were at risk for pregnancy. Testosterone use is it is a teratogen in the sense that it will virilize an XX fetus, and so something that patients should be aware of. As the pregnancy goes along, assuming this is a desired pregnancy, you may at some point want to discuss chest feeding, the preferred term for breastfeeding in transmasculine patients. If they've undergone mastectomy, this is likely going to be impossible, but you can talk about donor milk or partner lactation. If they have a patient with breasts that can produce milk, then you can consider inducing lactation in their partner. Throughout the pregnancy, acknowledge that the pregnancy itself may increase dysphoria, that they're going to want to have a good support system in place, and then acknowledging that lack of gender-neutral pregnancy information. So in terms of different terminology that you may use, and this goes not only for pregnancy, but really anything within gynecology that tends to be gendered. I've gotten in the habit in a lot of my counseling of replacing woman with person or people when I'm talking in a generic context. So for example, counseling a patient about fetal movement counts, you talk about if a person doesn't feel a baby move 10 times in 2 hours, then they should call their doctor's office, rather than if a woman doesn't feel the baby, she should call her doctor's office. So it's relatively easy and natural to make these little changes. You can talk about childbearing reproductive organs rather than female reproductive organs, and then talking about parental rather than maternal. Something, when I was giving this presentation at one point, one of our ultrasonographers actually brought up, how do you address the issue of fetal sex with patients? And I have to admit, at the time, it was something that I had not really thought about. Patients are oftentimes very excited. It's really their primary motivation in going for their anatomy scan is to find out if they're having a boy or a girl. And we tell them it's a boy or it's a girl, but what do we really mean when we're saying this? Now it's actually extremely common that we find this out at 10 weeks when they get their NIPT. But this is really indicating genetic sex. So you might tell a patient, we can offer you cell-free DNA testing. It will tell us the genetic sex of the baby based on their chromosomes. When the results come in, we can tell you this information. And then, if they do want to know, you can say that your cell-free DNA shows that the baby has male chromosomes, or the sex of the baby based on the genetic test is female, if you want to kind of boil it down. Same thing with the anatomy ultrasound. What we're looking at is just genitalia. When you're scanning and you get to that part, you can tell patients, I can see the baby's genitals. Would you like me to tell you what I see? And then you can say, I see a penis, so rather than saying it's a boy. So again, just something to kind of think about, because I actually had not thought about it until this was brought up. All right, so now going more specifically into gender-affirming therapy that can be provided within the context of obstetrics and gynecology, and I'm going to start with gender-affirming hormone therapy. I would say that, by far what I do the most of is transmasculine gender-affirming hormone therapy, so providing testosterone and androgen therapy for patients who are designated female at birth. But there is still definitely a role for transfeminine patients as well. So patients who are designated male at birth and providing feminizing hormone therapy. But regardless, in both cases, there are some criteria. So this is taken from WPATH, the World Professional Association for Transgender Health. And in general, it is the patient should have a marked and sustained gender incongruence, fulfill diagnostic criteria if it is required by a healthcare system, identify and exclude other potential causes, ensure that any concomitant mental or physical health conditions are adequately assessed and treated. Patients should have the capacity to consent for their treatment and should have the capacity to understand the effect of their treatment on reproduction. So this is all very aligned with an informed consent model. So traditionally, the model of hormone therapy was a mental health model. So patients needed to have a mental health professional attest that they had a diagnosis of gender dysphoria or gender identity disorder prior to referring them to a prescribing provider. But this has been seen as posing some unnecessary gatekeeping and additional barriers. So now we have, for the most part, really transitioned to an informed consent model. So this is much more collaborative. It involves a lot of shared decision making. This is really how we prescribe the majority of our other medications and procedures. And it's really promoting the patient's autonomy in the whole process. So as a prescribing physician, you're going to inform the patients of the risks and the benefits and the alternatives, confirm that the patient understands and can provide informed consent. And then your role doesn't end with the prescription. This definitely is a process. Again, patients are going through a big life transition. So you have to be able to provide ongoing guidance and support. We refer to this as informed consent model, but a written informed consent is not actually required. You just sort of document it. Here at Penn, we have our EPIC or Penn chart consents that are available that we tend actually not to really use. We just give them, we print them out and hand them to patients as information sheets, but we don't require patients to sign anything anymore. Mental health letters may actually be required by insurers in order to receive coverage for medication, although in my experience, this has become vanishingly rare. And most of the time, this is not necessary just for hormone therapy, but it is still the norm for surgery. Then we'll get into that in a little bit. And I tell patients that even though I don't need a mental health provider to provide a diagnosis to me, therapy is probably still a really, really good idea. The patient, if they aren't already tied into therapy, probably should be, just because they're going to be going through a huge life transition, and therapy is likely to be beneficial regardless. So at the initial visit, how do I conduct my initial visit for a patient who's coming to me for hormone therapy? So I, just might do my general medical and surgical history. I talk to them about their gender identity. So what was the timeline? When did they start, having these thoughts that they may have a gender identity that is not cisgender? What have they done? Have they do they have a new name? What pronouns are they using? Who are they out to? And then we'll get into a little bit about, sexual history, parenthood desires. Are they thinking about becoming a parent in the genetic sense in the future? Talk about the GYN history for patients who are assigned female at birth. Really go over what their support system is going to be through this. And then we actually get down to sort of talking about the risks, benefits, and alternatives to hormone therapy, which we're going to go over. So masculinizing hormone therapy involves providing androgens to create virilization. This table sort of has the effects that I go over with patients when they start testosterone therapy, when they can expect to start to see some changes, which you can see from the table. Patients often notice changes very quickly, but it can take years to get the true maximum effect. I always explain to patients, if this is somebody who's starting as an adult, having already gone through puberty once, I tell them they're going to go through second puberty, and puberty, unfolds over the course of several years. I put a star by the changes that are expected to be less reversible if they were to stop hormone therapy in the future. So if they develop facial and body hair growth, that will slow down, but probably not completely disappear. If they lose scalp hair, it's not going to grow back. If they have clitoromegaly, it's not going to decrease. And if their voice changes, it's not going to go back again. So most hormone therapy is given either as injectable testosterone or transdermal testosterone. I'll talk a little bit about injectable first. So there are two kinds commercially available. They are interchangeable in their dosing. They are administered usually subcutaneously. It's much easier and more comfortable for patients to self-inject subcutaneously, and that's done weekly. Or it can be given as an IM injection every 2 weeks. There's greater peak to trough variation there. And also patients don't tend to like to give themselves IM injections. The usual starting dose is around 40 to 60 milligrams of testosterone weekly, or double that if you're doing every 2 weeks. But this is really very titratable and individualizable. So patients can start at a much lower dose if they want slower changes to see sort of how they feel on it. If they're worried about side effects, you can start really, really low with that. There's also transdermal preparation, so patients who have a needle phobia or just prefer not to self-inject. There are two commercially available gels. They come in pumps or packets, and the actual product that's covered by insurance tends to vary a little bit. The gels are nice. There's less peak to trough variation. The changes are generally a little bit slower as well. There is some variability in the absorption between patients. But patients self-apply. It's usually to the arms and shoulders or the abdomen or the thigh, areas that are easily covered by clothing, because this is something that can transfer to partners or anybody who comes in contact with the application area. So patients do need to be informed about that. And again, it's around 40 to 50 milligrams of testosterone as the starting dose, but patients can use lower doses. Because it's already pre-measured in either a pump or a packet, it's hard to do partial doses here, so it's a little bit less customizable. There are other things out there. There's long-acting injections, there are implantable pellets, there's a patch, there's an axillary solution, and oral tablets that have become available more recently. These are all used less commonly, but patients who have contraindications or have tried and not done well on the two more common forms may want to switch to one of these. So important, obviously, to talk to patients. What risks are they assuming by starting testosterone therapy? So first of all, keep in mind that what we're going for here is testosterone in the sort of quote unquote normal cisgender male range. So their risks should approximate the average person whose body produces that amount of testosterone. But we do talk about things like polycythemia. So the anabolic effects of testosterone do increase red blood cell mass. Patients will gain weight largely due to just body composition changes. There's going to be acne, there's going to be balding. Both of these things are just direct testosterone effects on skin and hair. And it may unmask sleep apnea through changes in the trachea, as well as changes in distribution of soft tissue in the neck. Things that are possibly increased but have a lot of interplay with other risk factors are things like hyperlipidemia, cardiovascular disease, hypertension, all things that we know tend to run more commonly in cisgender men. And so I usually tell patients that over time on testosterone for a long enough time, there are other sort of genetic and lifestyle risk factors will play into having a more, sort of quote unquote masculine risk for cardiovascular disease. Luckily, there is no evidence of any increase of any type of cancer risk associated with androgen therapy. So you've got a patient started on it. How do you monitor your patient? So at the beginning, you're checking labs about every 3 months. And then after that, every 6 to 12 months. Sometimes patients at the beginning want more frequent lab tests. I'm usually happy to provide that to them because they just sort of want to know that things are working before they can see the actual changes. The labs that you should be checking, so check a serum total testosterone, get that drawn about halfway between injections, or if they're using transdermal, tell them not to apply it on the day of the blood draw. And you're looking for that 300 to 1,000 nanograms per deciliter normal male range. We also want to see that their estradiol is relatively suppressed, and then check a CBC to monitor for polycythemia. And if you need to make some dose adjustments, like I said, injectable testosterone is the easiest. You can do 10 milligram increments. Transdermal, it's a little tougher. So you basically have to do an entire additional pump or decrease it by an additional pump or packet. All right, and then, importantly, and this is actually a reason why patients will often get referred to me. So they're seeing a PCP for their testosterone therapy, but they're starting to have some side effects specifically related to pelvic organs that the PCP doesn't feel able to take care of. And so they send them on to GYN. So uterine or pelvic bleeding, really, really common. So testosterone usually results in very rapid amenorrhea. Patients oftentimes give a story of they start taking their weekly testosterone injection and they never get a period again, and they're thrilled with that. But sometimes the bleeding persists. So it could be due to incomplete suppression, their testosterone level isn't quite high enough to suppress their axis, or their estradiol is elevated, again, incomplete suppression or maybe aromatization. There could be any of those structural causes that we would look for in anybody with AUB, polyps, fibroids, hyperplasia. So I usually start with checking some hormones, making sure that we're at goal, check a pelvic ultrasound to see if there are any structural abnormalities. Now, again, patients may have a lot of difficulty with a transvaginal ultrasound. You can always start with a transabdominal with a really full bladder. It can oftentimes give you sufficient information, or have that shared decision-making conversation about why exactly a transvaginal exam might be really important. And so then, depending on what you find, change their T dose. consider adding an aromatase inhibitor, especially for a patient who might have a lot of adiposity and they're really aromatizing a lot of their tea. Although again, there's some long-term effects that we want to avoid there. Add a progestin in, so just to induce that uterine atrophy. And if you find something to remove, go ahead and remove it. I will say though that it takes a lot of trial and error, and this is a fairly common reason that patients will decide to eventually just go ahead and get a hysterectomy. Pelvic pain, also very common. So again, it can be due to any sort of the common pain etiologies that we're used to in anybody who has uterus and ovaries, so endometriosis or fibroids. Patients will often notice a testosterone cyclical effect with peak and trough variation in their pelvic pain. It may be due to vulvovaginal atrophy. It might be due to pelvic floor dysfunction. So there's this interesting, again, theory, not necessarily proven, that testosterone is causing muscular changes. It's imposing a more masculine musculature on a feminine skeleton, and it may lead to some imbalances there and cause some pelvic floor dysfunction. Pelvic floor therapy is something that I think we realize benefits so many people with pelvic pain, and that is definitely the case for trans patients as well. It's just making sure that you have a pelvic floor physical therapist that you can refer them to who's really comfortable and competent in trans care. So again, with the pain, you're probably going to start with some imaging like you would with anybody who has pelvic pain, and a pelvic exam as well. And then, again, depending on what you determine the etiology is going to be, is going to dictate your treatment approach. Vaginitis, again, very, very common. So patients on testosterone will become very atrophic. It leads to elevated pH, alteration in the microbiome similar to cisgender menopausal patients. Obviously, you're going to want to look for anything like yeast, BV, STIs. And then DIV, desquamative inflammatory vaginitis, is actually a condition that we see fairly commonly in the trans population as well. So in cisgender women, it tends to be associated with the perimenopausal period. And with the hormonal alterations during especially the early parts of testosterone therapy, it seems like that also can set off this condition. And again, the management doesn't really differ very much. The evaluation doesn't differ much from what you're going to do in a cisgender patient. Just think a little bit differently about the frequency of some of these etiologies. And then something that patients also are they know to expect, but they are always a little bit alarmed when they start losing their hair. So, I always tell patients this is an expected effect. Look at your male relatives. If your brothers are bald, you're probably going to lose your hair too, but we can try to mitigate that. So patients can start using Rogaine topically. You can prescribe them oral finasteride, and you can also try, manipulating testosterone dosing a little bit to keep them sort of in the lower range. Although again, it may not have much of an effect if they just have a genetic predisposition to androgenic alopecia. All right. Moving on now to feminizing hormone therapy. So like I said, a little bit less common that I will see patients for feminizing hormone therapy, but certainly not rare. And here is the graph of the expected effects in the timeline. So again, changes do start pretty quickly, although some of those earliest changes are sexual side effects. So the rapid decrease in testosterone really lowers sex drive and sexual function fairly quickly. Patients are really eager to see physical changes. They're really eager to see breast growth and body changes, and those tend to start slowly and really take a long time to reach maximum effect. As opposed to testosterone therapy, where there are a lot of less reversible side effects, there are very few actually with feminizing hormone therapy other than breast growth. Any breast growth that is achieved is not going to regress if estrogen is stopped. And overall, the regimens for feminizing hormone therapy are somewhat more complex. I think that we all know as OBGYNs that the sort of female reproductive hormone axis is more complex than the male. And this is certainly the case with gender-affirming hormone therapy as well. So for feminization, the mainstay obviously is estradiol. You can use oral estradiol. It's really cheap. It's readily available. Patients can either swallow it. Some patients like to do sublingual to theoretically bypass the first pass metabolism, but there isn't actually any evidence that it really matters. If the dose is at 4 milligrams or less, you can do once daily. The higher doses than that, given twice daily, just for tolerability. And generally, once you're up to around 8 milligrams, you're going to want to convert to another formulation. So that brings into play the injectable estrogens. So there are a couple out there, estradiol valerate and estradiol cypionate. And these, similarly to testosterone, are given subcutaneously once weekly or IM every 2 weeks. The dosing is more complex, though. So these two formulations, first of all, the injectable formulations are not equivalent to each other. And there's also not a good equivalence to the oral dosing. So if somebody started on oral and needs to switch over to injectable, there's no formula that you can really do to convert exactly. And my general principle is, if I'm going, even if they've been on the highest dose of oral estradiol, if I'm switching them to injectables, I'm going to start them at the lowest dose of injectables, because it just tends to achieve much higher serum levels. So menopause HT preparations, in terms of alternative forms, menopausal HT, the dose is too low. Patients aren't going to get any real feminization from it, even if they're combining multiple patches. And then ethinyl estradiol, so birth control estrogen that we find in a pill, patch ring. So there's just a higher VTE risk. There's no real way to monitor serum levels. So a serum estradiol level isn't actually going to measure ethinyl estradiol. So it's generally avoided. In conjunction with your estradiol, though, you're going to have to suppress their androgens. It is often difficult to get a serum estradiol level that feeds back at the level of the hypothalamus and stops androgen production. I will say, though, that this paradigm is changing a little bit more recently. So it used to be that we kept patients at a relatively low serum estradiol level, and now we've been allowing them to get a little bit higher. And it seems like now, when patients are kind of running serum estradiol in the 200 to 300 range, that is often enough to suppress androgens, and it doesn't seem to be leading to any increased risk of adverse effects. Again, data is sparse on this. But if the patients are at a lower dose, or when they're just first starting out and titrating dose, we might start with spironolactone. So it's a potassium-sparing diuretic. It is a potent androgen blocker, and it's generally well tolerated in patients. You do have to keep an eye on their potassium levels. You can also use 5-alpha reductase inhibitors like finasteride or dutasteride. They're not actually androgen blockers, but they do stop testosterone from being converted into the more potent dihydrotestosterone. And so this can be helpful for patients who can't tolerate spironolactone. A couple of other things out there. So you can just completely suppress their axis with a GnRH agonist. This is used really more in puberty suppression, but some patients, even in adulthood, will use it as their anti-androgen. It can be hard to get it covered, just as for any indication. And then there are even more potent androgen receptor blockers that are used, for example, in androgen-sensitive cancers, like bicalutamide. These are less preferred because they have rare side effects, but extremely serious side effects in terms of fulminant hepatic failure. Patients will oftentimes ask about progesterone, or providers will be curious about progesterone as an aspect of feminizing hormone therapy, and it's a little bit controversial. So, we all know progesterone is really pretty safe. There are very few contraindications for progesterone other than a progesterone-sensitive cancer. It's more that the benefits are kind of unclear. So theoretically, it may help with breast development. So we extrapolate this from the delayed puberty or Turner's literature, where progesterone as an adjunct to estradiol can help with breast contour and shape. Adding progesterone may help to suppress testosterone. It can actually, patients anecdotally report feeling better on on progesterone, and so we'll oftentimes add it for that. And for some patients, it also helps with libido. So if patients ask for it, I have very little hesitation in giving it to them. I use just, regular oral micronized progesterone, either the 100 or the 200 milligram dose. You can give it daily. If patients want to, sort of mimic a cycle, you can give it cyclically. And then if patients specifically are interested in breast development, I usually have them on estradiol for a couple of years before starting the progesterone. Again, if you think about it physiologically, this is sort of what happens at puberty. So thelarchy starts first. There's a high estrogen level and no progesterone because menses haven't yet started. And then after menarche, patients start producing progesterone. So if you think about giving them a couple of years of estradiol alone before starting progesterone, you're sort of mimicking puberty. Again, anecdotal, who knows if it's really ultimately helpful. It's probably a lot of individual variation. Risks here. So, with all estrogens, there's that slight risk of VTE. There is a higher rate of gallbladder disease. There is an alteration in lipid panels with a tendency towards higher triglycerides. But again, most importantly, no increased cancer risk. Monitoring. So again, you're checking estradiol. And like I said, we have been more permissive in allowing levels to go higher. You want to make sure that testosterone is suppressed. Check that potassium if they're on spironolactone. And then prolactin levels can get elevated with higher doses of estradiol. And if that's the case, you want to check to see if they have any symptoms of frank hyperprolactinemia in terms of the galactorrhea or any evidence of an adenoma. For dose adjustments, so you can titrate to physical goals, to serum levels. You can slowly increase the oral or the injectable by about 2 milligrams daily or weekly. And then also consider increasing it if the testosterone isn't completely fully suppressed. As I mentioned, it's a little bit tricky to convert between oral and injectable, so I just started the lowest dose of the injectable. And spironolactone, you can increase by about 50 to 100 milligrams daily, and this is always given BID. For patients, reporting side effects from their feminizing therapy. So I think one of the most common ones, like I said, is the decreased libido. You can do a little bit of add back testosterone if patients are really very suppressed with their testosterone. But, again, patients should be, engaged in shared decision making in terms of the potential for reversal of their feminization. And then if it's specifically that they're just having sexual dysfunction in terms of erectile dysfunction, then Viagra or Cialis generally work quite well. And then just, quick comment, not every patient is really going for the binary. They may not be going for, a fully feminized or a fully virilized presentation. And so you may be playing around with doses that are, sort of not quite getting them into the, quote unquote, cisgender ranges. And I think here the most important thing is telling patients that it's not exactly like ordering off of a menu. It can be difficult to achieve some of their desired effects while avoiding others. So there just tends to be a lot of smaller dose titrations and management of side effects early on. Getting close to wrapping up here, but I want to spend a little bit of time talking about the role of gynecologists in surgery. So by far the most common for the general gynecologist is gender-affirming hysterectomy. So about 75% of trans men do plan to have a hysterectomy as part of their transition, either for just reasons of gender affirmation, the desire to not possess an anatomic structure that they find very dysphoric. They may have pelvic pain or bleeding that's refractory to other management. And they might just not want to ever have to worry about developing any sort of disorder in any of these organs. So the criteria are all the same as for hormone therapy, plus generally about 6 months of hormone therapy as appropriate to their goals, unless the hormones are not clinically indicated. So there is actually some information out there specifically for trans patients considering hysterectomy. There's this website, histo.net. It is largely a patient-run and driven website. So as with all patient websites, we know that some of the information cannot always be 100% accurate, but it is actually pretty good. I like it because they do have torso pictures that show incisions on a male torso rather than a female torso, so I'll use this a lot to show to patients. For pre-op for a hysterectomy, I talk to patients again about the pros and cons of doing a pelvic exam or getting imaging prior to a hysterectomy. These are often young, healthy patients with no risk factors for pelvic pathology. And so we talk about the fact that if they are very averse to a pelvic exam, maybe we can skip that, but that runs the risk that I might be surprised at the time of surgery. That has only happened once or twice to me with sort of like a more adenomyosis type uterus that was just a little bit harder to get out, but didn't ultimately change the plan. Again, talk to them about making sure they're up to date with cervical cancer screening. Insurance coverage, not too bad actually. So New Jersey Medicaid is going to cover this. It's increasingly covered by private insurers. Most insurers, including Medicaid insurers, are going to require a letter. The WPATH guidelines were updated last year. They require only one letter. Some insurers are still requiring two. Patients, most of our minimally invasive hysterectomies on any patient, they're going to have a same-day discharge. If they do need to stay overnight, we admit them to a general surgical floor, not to our usual women's health floor. Have them check in at 4 to 6 weeks. Something I stopped doing a few years ago is I don't require patients to have a postoperative pelvic exam unless they're having any ongoing pain, bleeding, or discharge, which is pretty rare. And then patients are usually really happy that they no longer need a pap smear as long as they haven't had any history of severe dysplasia. And then again, just in terms of approach, this doesn't really change. Most patients will be good candidates for a laparoscopic hysterectomy. Vaginal hysterectomy sometimes is difficult just because they may have a narrower atrophic vagina, but laparoscopy is generally good. The other aspect that we're oftentimes called on to provide care for is maintenance of the neovagina. So after patients undergo vaginoplasty, usually their immediate, first 4 to 6 months management is taken care of by their plastic surgeon, but the long-term maintenance tends to fall to a gynecologist or another healthcare provider who's comfortable with this. Patients who have had a neovagina created, they need regular lifelong dilation or penetrative intercourse to maintain their length and their width. If patients are doing well with their dilation, there may be no issues. Patients will oftentimes come in with pain or difficulty with dilation. They may have bleeding after dilation. And so an exam can help to determine whether or not there's some stenosis or shortening of their canal, if there's any granulation tissue left over, or even breakdown of the graft. The vaginitis that tends to occur in the neovagina, it is a little bit different. So again, this is usually lined with keratinized skin. It has a higher pH. The flora is very different. It's usually just general skin flora. There's no lactobacillus. So when patients come with discharge and odor, it's usually not going to be BV. It can be normal skin secretion, so sebum and sweat and slough cells and bacterial overgrowth that can happen in any sort of dark, damp area. It could be an STI, although relatively rare. It could be a skin disorder. Patients can get eczema, psoriasis within the neovaginal canal because it's keratinized skin. So, in contrast to what we tell our cisgender patients, transgender patients should douche regularly. Warm water and gentle soap is generally fine. If they are diagnosed with an STI, treat it. If you can't find anything specific, you can try some topical metronidazole. Again, it may not ultimately be that beneficial if it's not truly BV, but it can get rid of some smelly anaerobes if they're there, and then treat the dermatologic conditions, including potentially referring them to a dermatologist. All right, so that was my last informational slide. I put up here some resources. So UCSF and Fenway out of Boston have great resources online. WPATH and the Endocrine Society publish some official guidelines on care. And then in terms of pregnancy resources, there are fewer official resources, but there are lots of community resources out there that can be really helpful, and patients will frankly oftentimes find them on their own. So I'll stop there, and I really welcome any questions you might have.
Thank you, Dr. Vasquez. Thank you so much for that excellent talk.
Let me
Does
start.
anyone?
Yes, let me
Yes,
start.
go ahead.
First of all, I want to thank you for this really comprehensive, just overview of care for this population. But I think a practical question that comes to everyone's mind is we have should refer these individuals to of all gynecologists and obstetricians.
Dr. Bachman, I'm sorry. I don't know if it was just me, but you cut out intermittently between there, so I didn't hear your entire question.
Sure.
Dr. Bachman, turn off your video camera so that all of your bandwidth goes to the audio.
Okay. What I was asking was, should this be a specialty onto its own, like REI, like high risk OB, like urogynecology, because as you went through all of the issues that have to be addressed, it really it really is a lot for the general OBGYN to absorb and provide care for. So that's what, I just wanted to start the questioning with.
Yeah, I think that's a really good point, and I could certainly see that the field may move in that direction at some point. I think right now where we're at is maybe more along the lines of something like menopause. We've got the Menopause Society, we have providers who can become certified menopause providers, and it certainly is a subfield that fits well within general gynecology, but requires a lot of additional specialized knowledge. I think that's kind of where we're at right now with gender care. It's definitely a knowledge base that you can still incorporate within a general GYN practice, but it does require some additional sort of, education. So I think that, what I always hope for is that for people who want to incorporate this into their general GYN practice, it's very, very possible. For others who don't necessarily have the bandwidth, maybe they have other clinical focus and interest, then yes, it's great to be able to refer to somebody who does have that, just sort of, hear anyway what we do with menopause.
Because one other follow-up is one would need additional visit time or encounter time rather than just the routine, gynecologic visit or OB visit.
Yeah, potentially yes. Although I will say that, I think all of us, who are sort of, have a niche in a certain area, we kind of have our like, our little spiels that we can do pretty quickly. I can do a gender affirming hysterectomy consult in a 20 to 30-minute visit. I can do an initial hormone intake, usually in a 30 to 40-minute visit. So yeah, it can potentially take a little bit more time, but I think the more comfortable you get with it, the faster you're able to do it. But yeah, something you have to take into account if you're building this into your practice.
Other questions?
Can I just ask one other question? And that is, when this is a very controversial topic that I hear all the time, but what is the age that one should do active intervention for an individual who identifies as, or who parents feel the individual, the child, is trans? Because this has been very controversial.
Oh yeah, certainly, and it will continue to be. So I think that the general consensus in pediatric and adolescent medicine, and just overall in the gender care realm, is if a prepubertal child is expressing significant gender incongruence, give serious thought to puberty suppression. Not starting cross-sex hormone therapy, but puberty suppression to give some time to put the brakes on something that may increase dysphoria, and just give some more time for that decision to unfold. And then depending on how the young person does, they're, consider starting cross-sex hormone therapy maybe around 15 or 16. Now, this is going to be a lot later than their peers going through puberty. So they're going to stay, sort of relatively in a more, childlike presentation for longer, and that can be difficult socially. But that seems to sort of be where most adolescent medicine providers have landed.
That's basically what pediatric endocrinology does here at the Proud Gender Center. So that just the last question, and that is, it goes along with what I said before, and that is, should OBGYNs be providing the hormonal therapy, or should endocrinologists? Usually at our site, we have the adult endocrinology and pediatric endocrinology doing hormonal therapy.
Yeah, I think it's going to be very context dependent. So actually interesting here at Penn, our endocrinologists are almost completely out of it. There's almost no endocrinologist who does. They almost all, the adolescents go to, the children and adolescents go to just the adolescent medicine center, and adults usually either go to family medicine or OBGYN. So some of it will depend on the training and interest of the providers within your health system. But I definitely think that this is something, again, we prescribe hormones for so many different reasons that it really it can fit well within a OBGYN practice.
Yeah, I agree with that. And it's interesting that I trained at Penn, that Penn has a different philosophy than Rutgers.
All right, well, again, thank you so much for this excellent talk.
Thank you.
We very much
Yeah.
appreciate it.
Thank you so much. Truly appreciate it.
My pleasure. Thank you.
All right, so we're going to end here. I hope everyone has a successful and productive day.